My name is Gautam Malhotra. I'm a physiatrist in New Jersey, clinical professor at Rutgers, New Jersey Medical School, the Kessler program basically for PM&R. And this lecture is a consolidation of 3 lectures that I used to give the residents starting from when I was a senior resident. And it was also given to the Kessler board review course. It's called Intro to Electrodiagnosis, but really what it is a fill-in of all the gaps that we had of the topics that kind of weren't being formally covered, which included pretty much the first 4 chapters of Daniel Dumitru's textbook on electrodiagnosis. So it included the physics, neurophysiology, volume conduction theory, and the instrumentation. So just for, I do have other lectures that kind of sneak this in a more clinical way, but I figured it would be good to also share this since, you know, it's kind of section on this, section on this, section on this. So hope you enjoy. I also want to make sure that you do actually go and look at my other lectures on the SNAP and the CMAP, which I think do a better job of describing all of this. By the way, these were my affiliations at the time. Yeah, so these are all kind of like bonus slides to those other lectures. So I'd rather you not watch this lecture first. You probably should watch those first. And these kind of get into some like esoteric stuff that might not be as useful to the first-time learner. This is more like additional to those other lectures. So the way we're going to do this is we're going to start with an introduction to physiatry and electrodiagnosis. We'll talk about what happens in an electrodiagnostic encounter in case you've never seen one and you're trying to learn electrodiagnosis. Then we'll talk about physics, basically, electricity. We'll talk about what I call the 2 black boxes. The first black box is the equipment. And then the second black box is the whole body, basically the cell physiology, neurophysiology, etc. So let's start with intro to physiatry and electrodiagnostic medicine. So just indulge in a little dumbed down intro. Physiatry is basically the specialty where we diagnose and treat patients of all ages in 3 main areas of medical care. The first one is physical medicine, the second is rehabilitation medicine, and the third is electrodiagnostic medicine. Physical medicine is the diagnosis and treatment of musculoskeletal injuries and pain syndromes. This is what you see in your outpatient clinics. So aches and pains, numbness, tingling. While rehabilitation is restoring function in patients with severe impairments. These are like your inpatient rotations. So things like stroke, brain injury, spinal cord injury, multi-trauma, burns, amputations. And we, as physiatrists, will direct a team of nurses and therapists in an interdisciplinary fashion to help with the management of these conditions. The third is electrodiagnostic medicine, and I say it's to figure out physiologically what's going on with your nerves and muscles. And I put this picture of a car hood open because I say an MRI is sort of like opening the hood and seeing what happens, seeing what's going on, while electrodiagnostic testing is when you turn the key of the car and see what's happening then. So there's usually 2 parts. The first part is usually nerve conduction studies, and the second part is electromyography. PM&R is the only specialty of medicine requiring special training in electrodiagnostic testing. So what is electrodiagnosis? Well, the human cells are constantly generating electrical discharges, and these can be displayed on a screen. And when you have a disease, it alters the way these are going to look, and you can use interpretation of those changes to direct diagnosis and clinical management. The electrodiagnostic medicine professional is actually a clinician. So that means, like any clinical service, you take a history, you do a physical exam, then it's followed by the nerve conduction studies and electromyography. Anyone performing electrodiagnostic testing must first understand how these discharges are generated by the cell membrane, which is membrane physiology, and how they propagate through the body, which is volume conduction theory. So meaningful interpretation of electrophysiologic data can be reliably performed only after the clinician appreciates these concepts of membrane physiology, volume conduction theory, and instrumentation. Most people generally treat the body and the equipment as if they're black boxes. You do something to the black box and then something happens, which is, I guess, fine if you're a technician. But my job is to try and expand what's inside these black boxes for you. So now we've talked about the physiatrist and what electrodiagnostic medicine is. Let's talk about what an electrodiagnostic encounter looks like. This is a play-by-play of everything we're going to go through, and the slides are meant to bring a smile to your face and a little bit of silliness to them. So the first here is that we are usually consulted or referred a patient for electrodiagnostic testing, and it could really be any complaint that is sent for the testing. So we want to make sure that we're not anchored and biased to whatever they're telling us the problem might be. So this is a slide just to show that this is different from a regular consult because the emphasis is on us as a technician. So you may want to be more direct and to the point in all business without losing professionalism or compassion or congeniality. And in this picture, I just wanted to point out that the gentleman in the white coat, Dr. M, is the doctor and Dr. Abbasi is the patient. So first we take a history, and the whole point of this is to establish the differential and figure out which body system is involved. Is it really neurological, musculoskeletal, psychological? Is it bilateral? Is it more proximal? This is going to help direct the physical exam. And the physical exam is essentially to confirm your thoughts from the history. It's going to help direct your electrodiagnostic testing, which is not set in stone. The physical exam usually is comprised of components that will help confirm the history, but also screening components to make sure that you're not missing scary things. Typically, the first part of the electrodiagnostic exam is nerve conduction studies. Electrodes are placed over nerves or muscles, and the nerve in question is stimulated at different places. The signal goes through a black box. Waveforms are generated on a screen, and thus properties of the nerves and muscles can be extrapolated. Here you can see the attending physician. Your attending physician is probably not looking too carefully at what you're doing. This is kind of boring for them, but the patient definitely does feel some discomfort during this. Typically, the needle electromyography is the second part or the last part of the electrodiagnostic exam. A needle is percutaneously inserted into the muscle to irritate the membrane. This irritation elicits discharges from the membrane. Again, through the black box, waveforms are seen on a screen, and the electromyographer then analyzes it. And as you can see here, the attending is never satisfied with your technique, no matter how hard you try to help them, no matter how hard you try and follow their rules. Again, this is an uncomfortable procedure. In fact, after having all of the needles in their body, I think you owe them an explanation of the findings. It's not always good news. And although the report is not yet complete, preliminary findings should be discussed with the patient. They probably feel entitled to an explanation after being shocked and stabbed. So practically that's it. You can basically just follow the algorithms and go through the routine without knowledge of the theory behind it. And the two black boxes, like I said, are the patient, which is anatomy, histology, and physiology, and the other is the equipment. So why bother learning the basic science and how waveforms are generated? Well, the question and answer are the same. To know why is what separates us as physicians from technicians. So anyone who's not interested in knowing why probably should leave this lecture now. The rest of you are committing yourselves to pay attention and really try and get it. So we've now finished with the electrodiagnostic encounter. It's time to talk about physics, basic electricity. And I'm going to have Marvel's Electro in pretty much all of these slides because I got really into putting him into these slides when I first came up with this lecture. So what we're going to go through is charge, polarization, dipoles basically, voltage, current, resistance, grounding, voltage sources, Ohm's law, and capacitance. We're going to go through it pretty quickly. So start by picturing an electron. It's a tiny particle which is considered to be negatively charged. Electrons encircle protons, which are said to be positively charged. Like the poles of a magnet, opposite charges are attracted to each other, while similar charges repel each other. And this is just a fundamental observation of the universe, and we are not going to get into the modern physics to explain electrons and protons. So atoms are basically collections of protons and mobile electrons, and they make up all matter. So since all matter is made up of these atoms which have electrons and protons, if an object or a volume has an equal number of electrons and protons, it's said to be a neutral object. If there are more protons than electrons, it's said to be a positively charged object. And if there are more electrons than protons, it's said to be a negatively charged object. Now you can have a neutral object and separate the positives and the negatives so that they're on different parts of the volume. When that happens, we call it a dipole, meaning that it's polarized. It has positives on one side, negatives on the other. So we already discussed that opposites will attract, and that's a fundamental phenomenon of the universe. So if you take a nylon comb and draw it through your hair, basically the negatives, the electrons will come off the comb into your dry hair. And so then the comb will become positively charged. And so if you put that near lots of little pieces of paper, it will attract the pieces of paper. This is called electrostatic attraction. If you were to use wet hair, the electrons would, from the water, would actually, the electrons would be replenished to the comb, and you wouldn't have the comb being positively charged. But because it is positively charged, the paper's mobile electrons will migrate to the comb-facing side of their atoms. So the little pieces of paper become dipoles. The polarized paper is now attracted to the positive comb. So this is called electrostatic attraction. If the water gives back the electrons, that's called grounding, which is basically replenishing either positives or negatives. So let's come back to charge. It's measured in coulombs, and that's how many electrons it is. And since electrons move more freely than protons, positive charge is usually a reflection of a deficit of electrons rather than surplus of protons. If allowed to do so, oppositely charged objects will move toward each other until they're touching. The quantified amount of this attraction, or how driven these objects are to move, is called electrical potential, and that is equivalent to the word voltage. The size of the electrical force depends on two things: how highly charged the objects are and the distance between them. The more charge there is, the more force each charge feels. As the distance between the charges is increased, the force quickly becomes smaller. The force of gravity, a different kind of attractive force, is billions of times weaker than the electrical force. To simplify concepts in electricity, it's sometimes useful to use the analogy of water in a pipe. If you see here in this figure, each drop of water can be compared to an electron or a charge. The water just sits motionless in the pipe. Now picture that there's a pump in the system forcing water through the pipe. The new inclination for the water to move is analogous to the voltage generated by a power source, such as a battery. And note that in this diagram, he uses E instead of V to represent voltage. So, voltage is a relative phenomenon. It's basically comparing charge between two different locations. The Earth represents a relative zero voltage, since it has an almost infinite amount of ability to donate electrons or accept electrons. So grounding is when something touches the Earth, where it can get as many electrons as it needs, or it can donate as many electrons as it needs. So a grounded circuit is physically connected to the Earth. Without grounding, a circuit can pick up stray static electricity and develop dangerously high potentials, as occurs with thunderclouds. So basically, thunderclouds are storing all this charge up far away from the Earth, and then it builds up so much that there's an attraction, and then that's how you get the electricity between the Earth and the thunderclouds. So at this point, we don't think that the ground electrode is being used for safety reasons. It is being used to represent what zero charge would be, or zero voltage would be, so that the other electrodes can compare to that. Another similar example occurs when electrons are removed by walking on a nylon carpet on a dry day and then dispersed through a spark to a metal light switch. The spark is the flow of electrons, negative charges, from your body to the grounded metal plate. Any flow or movement of charges over time is called current, which is measured in amps or amperes. And 1 amp is 1 coulomb per second. So here's a couple of examples of charge moving, which is, as we defined, current. So here we see two volumes. One has positive charges and one has negative charges. So negative current is when negative charges are flowing. Positive current is when positive charges are flowing. And negative and positive currents propagate in opposite directions. If allowed, all the excess charges will flow between objects until both become uncharged or are of similar charge. So I used to talk about this. I believe that, well, first of all, you have to know that in electrodiagnostic medicine, down below the zero line is positive and up is negative. And I believe this is a reflection of the intra-axonal currents that were detected in the original electrical experiments done on axons. And now everything we do is outside of the nerves. So I believe that's why the positives and negatives are reversed. So if current is flow of charges, there are two different types of current. One is direct current, which is where it's one amount of current that is maintained. That's DC, such as what you get from a battery. Alternating current, or any kind of varying current with time, is a different type of current. So the rate of the variation of the alternation of the alternating current is called frequency, and the frequency in the wall socket is 60 cycles per second in America. I believe it's 55 in Europe. Most muscle action potentials are variable, and they range from 50 to 200 hertz. And I'm going to talk to you about impedance and resistance later. A few more physics items that we may not have covered, but basically, if you separate two charges, then you generate an electric field in space. And these are those isoelectric lines that you can see from when you used to do physics. We already talked about how excess electrons will want to move to another object until both locations become uncharged. And a voltage source or battery maintains a constant voltage between two locations despite current flowing by progressively removing the charges from the electrons from the positively charged area as fast as they arrived. A cathode replaces electrons, and an anode removes the electrons that have flown to it. We talked about how the greater the voltage of attraction across a constant pathway, the greater the current or flow of charges per second. However, the pathway will also determine how many charges can flow. Resistance is the description of how difficult it is for charge to move through a certain path. A greater charge flow can occur through a larger cross-sectional area, which decreases the resistance, analogous to greater water flow through a larger pipe. And certain materials called non-conductors or dielectrics can accumulate charges more easily, thus making them more resistant. Conductors, such as metals, allow much more freedom of electron movement, making them less resistant, so they're conductors. So here I'm just showing that you can have a greater flow across a larger cross-sectional area, just like the pipe. And non-conductors we just talked about versus conductors. So electrical current flow is inversely proportional to the resistance, but it's proportional to the voltage. Mathematically, this is written as I equals V over R, or V equals IR, which is also called Ohm's law. And it's a very powerful relationship. So return now to the water analogy. The pump generating a push to move the water is analogous to a battery generating a voltage. The flow of water per unit time through the pipe is analogous to the flow of charges through a wire. A region of smaller cross-sectional area through which there is slowing of water flow is analogous to a resistor in a circuit. A series circuit occurs when there's only one pathway for current to flow. Each resistor adds to the overall resistance. Equal currents flow through each resistor, while the voltage drop across each resistor depends on the individual resistances. A parallel circuit contains branch points where voltage is equal across each resistor. Parallel resistances are calculated such that the overall resistance is always less than that of any single branch's resistance in the circuit. And this derivation is not going to be reviewed here, and also it's really not relevant, but just wanted to remind you about series versus parallel. Current is measured in amperes. Voltage, or the attraction of charge, is measured in volts. 1 coulomb of positive charge located 1 meter from 1 coulomb of negative charge in a vacuum is 1 volt. Most biological electrical signals involve very small values and are therefore usually measured in milliamperes and millivolts. Going back to our water analogy, picture a reservoir behind a dam. When pumping water toward the dam, all of the pumping action is going to lead initially to filling of the empty reservoir. The electrical analog of the reservoir behind the dam is a capacitor. Many residents have appreciated my description of capacitors because they didn't understand it during physics. So here goes. A capacitor consists of 2 flat conductive plates in very close proximity, but they're separated by means of a non-conductive dielectric film. It serves to store charge or energy on its plates, just like we talked about with the reservoir behind the dam. It stores the energy on its plates in the following way. So before the voltage is applied, and here's the battery, and this is the anode, and this is the cathode. So when the voltage is first applied, charges, let's just say positive charges, are moving down this wire onto this plate, and they accumulate on this plate. And they can't go across because there's either air or a non-conductive insulation in there. So this accumulation induces charges of opposite polarity to accumulate on the other side of the dielectric due to electrostatic attraction. So this is just like the comb and the paper, but let's take a look at the dielectric. So here you have the plate with all the positives on it, and the dipoles within the substance then align so that the negatives are attracted, because they're attracted to the positives, then the positives are going to be repelled by it, and they're going to be facing this way. So the entire thing becomes a dipole. And what happens is the positives that are accumulating here repel any positives that are on this plate and attract any negatives that might be on this plate. So the positives then leave this plate, they go down this wire, and they're also attracted by the negative pole of this battery. So what happened is you've got positives going here, collecting here. The positives leave this plate and go down here. So what has happened? Basically, a current has conducted across, even though it hasn't gone across, a current has conducted across the capacitor. This continues until finally all these positives are repelling each other so much that the force of the repulsion equals the force of the push from the battery over here. So if you had a larger surface area, you could store more charges. And the smaller the distance here between the plates, the more easily the opposite charges can be placed on each sheet due to increased attraction to the opposite plate's charges. Here's a nice picture again with the ENM. And it's really important because of two things. One is the plasma membrane serves as a capacitor. And the second is that the currents that occur at subthreshold stimulations are due to capacitive current, not due to charges going through the membrane. So because no actual current is flowing across the dielectric, but charges are moving, we can say a current exists until the capacitor is fully charged. Incidentally, if the voltage placed on the capacitor exceeds that which will cause the dielectric to conduct, the capacitor will explode. With a small resistance, the total charge movement occurs much faster, whereas the charge will take longer to accumulate with a higher resistance. How fast the capacitor charges is thus inversely proportional to both resistance and capacitance. Tau is the time constant. The larger the tau is, the longer time a given resistor or capacitor pair takes to charge or discharge. This is analogous to the time it'll take for the reservoir behind the dam to fill up. And we'll return to capacitors later. But basically, one other analogy I forgot to give is whenever you see your computer power light taking a while to dim after you've turned off the power or unplugged it, that's because the capacitors are discharging. They've stored all that charge and they can contribute to voltage so that you have a more stable source of charge. So yeah, we just talked about all of this. And capacitance is measured in farads. And if you have a battery applied to a circuit, the current that will flow will inversely decrease over time because of the buildup of the charge. Whereas with AC, you have constant changing of the voltage, so you have constant changing of the capacitance. And this is delayed by about, I think, 90 degrees or 45 degrees. I believe this is all excessive. So at this point, we've covered charge, polarization, potential, current, resistance, grounding, voltage, Ohm's law, and capacitance. I'm sure most physicians have skipped past these sections, but there it is for you. Dr. Dumitru felt it was important for you to understand this, so I felt it was important to summarize it. So we were talking about the black boxes, and I said how some clinicians might treat the patient and the instrumentation as if they were black boxes. They see that the black box responds in some manner after they do something without actually understanding what's happening inside the boxes. So is deconstructing the black box even necessary? Dr. Dumitru says, performing an electrodiagnostic medicine consultation requires a thorough understanding of how the electrophysiologic instrument processes and displays biologic signals. This knowledge will help the practitioner avoid misinterpreting erroneously derived data due to instrumentation errors as possible pathology. So this is an old picture that I had made. I know it looks like a 4-year-old did it, but basically this shows you everything that's going on. You have, if you looked at the black box, basically you've got electrodes. You've got these electrodes are connected to cables, and the cables plug into 2 different amplifiers. These 2 amplifiers, when summated, are called a differential amplifier. And the purpose of the electrodes is to form an interface between the body and the machine. The purpose of the differential amplifier is to reveal the difference between the 2 electrodes. The signal that results from this goes through some filters. The filters are trying to take out all the noise that we're really not interested in so that we can see what we are interested in. The signal is then processed, sent in parallel to a speaker or a computer. These days, we do not go to a monitor yet. We first go to the computer. So once it goes to the computer, it's stored as 1s and 0s, and it can be saved for manipulation, and then it's shown on a screen. So now what we're going to do is we're going to go through every one of those components. So the first one is electrodes, then the amplifier, then the filters, then we can hear it through the speaker, then a computer converts it, and then we can see it on a display. And there's a separate circuit that doesn't do anything to the waveform except initiate it, and that's stimulators and stimulation, which we'll talk about separately. So let's first start with electrodes. So now if we look at the same picture from Dumitru, where we're looking at the electrodes here, and you can see I tried to magnify them here. The electrodes have names called active, reference, and ground. However, more appropriate names would be electrode 1 and electrode 2 and ground, or E1, E2, and ground. Sometimes ground is referred to as G0 when people say G0, G1, G2. And G just refers to grid, which is from the old tube technology. So here we see an example of active, reference, and there would be a ground somewhere here. So we're going to cover all of these aspects of electrodes. First, the definition. Any conductive material can be an electrode, and usually it's metal. It was a term coined by Faraday, but if you look it up on the internet, it's also a Pokemon. So in electrodiagnosis, they're used to pick up very, very tiny signals in the microvolt to millivolt ranges, and so they need to be of good quality. We talk about two kinds of electrodes, surface electrodes and needle electrodes. So surface electrode materials, basically any kind of metal that readily conducts current. And there's many different things that have been used for it. I currently use the silver chloride EKG tabs, which have been shown to be equivalent in efficacy. They're flexible, easily alterable. They do cost to replace, and after about 5 or 6 up and downs, they do start to lose their stick. Some people have used saline-soaked felt pads, which have maybe fallen out of favor at this point for either the disposables or non-disposable metal electrodes. They can be a variety of shapes for different regions of the bodies, including discs embedded in plastic bars, self-retaining clips, adjustable wire nooses, or saline-soaked felt pads. Really, this is just for accessing a certain part of the body better. It's really important to have the electrode adherent to the body to get a consistent signal. Usually we use adhesive tape to secure the electrode, although there is a quick-drying, liquid, smelly, untidy, time-consuming adhesive which requires a drying apparatus called collodion. And you can also get a sticky electrolyte cream. I don't recommend these for routine nerve conduction studies or electromyography. I've already talked about this. The cup, so does size matter? Well, the cup-shaped disc diameter is up to 2.5 centimeters, and a larger diameter results in a larger surface to average. So it's going to be a little less specific, but it will be more sensitive. If you use a smaller one, then it'll be more specific. Just have good normative data so that, the size of the electrode, you know what you're dealing with. So we already talked about resistance and how how current will flow if there's a higher voltage and less resistance. So if that's true, and by the way, we talked about how impedance is resistance when describing varying voltages, and in the body, it's all varying voltages. So when dealing with surface electrodes, the problem with skin is that it's a giant resistor. Skin reduces the amplitude of potentials under investigation when surface electrodes are used, and the impedance of skin ranges from 500 to 9 mega ohms. One way to reduce impedance is to aggressively swab the skin with a alcohol swab, and what it does is it removes the dirt, the oils, the layers of dead cells. You can also use a pumice solution or fine sandpaper, and certainly people who are doing a lot of EKGs are familiar with these techniques. this is not a topic I'm going to go over. So when you have surface electrodes, you have to be very careful of where you're putting them. If you put them too close together, you can have issues. If you put them too far apart, you can have issues. So to totally bypass the resistor of skin, you can stick a needle into the body's volume conductor. This places it in direct contact with the extracellular fluid, an electrolytic solution which acts like the electrode cream or electrode gel of surface electrodes. There's two major types, monopolar needle electrodes and concentric needle electrodes. Monopolar electrodes can also be used as a cathode to perform near nerve excitation with a stimulator. But let's talk about them as surface electrodes for pickup. So monopolar needle electrodes are basically a solid shaft of steel that has a sharp point of a distal tip, and it's surrounded by Teflon except for the tip. So the shaft of metal serves as the E1 or active electrode, which we'll talk about later, and the tip results in a spherical recording region. So wherever that tip is, it's almost like a microphone picking up whatever voltages are in the area. For this reason, it only has one electrode, one piece of metal in there, so you do have to use other surface electrodes for the reference and ground, which we haven't talked about yet. Some people feel that maybe it's better tolerated than the concentric electrode because the tip pierces the skin easily and the Teflon-coated shaft glides readily through muscle. There are differences in the motor unit action potential pickup. Yeah, you'll see larger durations, possibly slightly larger amplitudes, and more polyphasics with the monopolar, but you'll get slightly more noise than you would with a concentric. The concentric needle electrode, as you can see here, it's the same as the monopolar, except that at the end it's a bevel rather than a point. And so this gives you a smaller hemispherical recording region. And then there's a shaft of, around the shaft of metal, there's the Teflon, but around the Teflon, there's more metal. And that metal can serve as the second electrode. So both E1 and E2 are right next to each other. And because you're going to find out with the differential amplifier that they subtract each other out, you get less noise. Some people would argue that you get more bleeding because you have this cutting edge of the bevel and that it may be more painful. We talked about what can happen with amplitudes and durations and polyphasics with the monopolar, so it would be the opposite here. So a debate continues as to which to use, as neither is the ideal needle. In the final analysis, personal preference and training biases seem to be the dominant factors in determining the type of electrode used in clinical practice. Just avoid mixing matching parameters between needle types and labs, and also develop reference data for both types of electrodes. I just wanted to go over a couple of other types of electrodes. The single fiber electrode is a modified standard concentric needle electrode where the central wire exits approximately 4 millimeters proximal and opposite to the beveled tip through a side port in the cannula right here, instead of extending along the length of the cannula to the beveled tip. In conjunction with an elevated low frequency filter, the diameter of the recording surface is very small, 25 microns, and that's small enough to record one single muscle fiber action potential. And so this is why this is called a single fiber electrode, because you can actually see multiple muscle fibers, single fibers of a specific motor unit, whereas with the other ones we talked about, you can only see the summated motor unit action potential. The bipolar concentric needle is a standard concentric needle electrode, except that a second wire is located within the cannula, and the wire serves as the electrode's reference. So the tip is still the active and the cannula is now the ground. It's larger, it's more painful, it's rarely utilized, and it significantly reduces noise and displays the motor unit action potential with markedly reduced duration and amplitude. I've never used it myself, I've never seen one in real life. Another type of needle electrode that may come up are subdermal electroencephalographic needle electrodes. They're used to record evoked potentials just under the scalp. They're real small and held in place with tape. They're disposable. And here's a summary slide with the different electrodes for final analysis. So we've talked about the electrode, but what about the little cable that's attached to it? The electrode cable can pick up stray environmental electromagnetic radiation, so it's important to keep them as short as possible, equal length, and separated from the stimulator cables. Their impedances should be checked regularly. I haven't checked impedances on my wires, but that's what Dumitru says. And there are requirements for those, which pretty much the engineers at the different cable companies are taking care of. One thing I can tell you is that if your cable's moving around like this, you're going to see that reflected in the waveform. So we've covered electrodes. The main point is the electrode is the interface, and it's an important component contributing to the waveform. So the next step in, or the next stage of generating the waveform is the differential amplifier over here. So bottom line thus far, the purpose of the electrode is to pick up the tiny voltages under them as cleanly as possible. The purpose of the differential amplifier is to reveal the differences between what's being picked up by those two electrodes and then amplifying that. So an amplifier is basically anything that will make something larger. So biologic signals have to be significantly amplified prior to analysis, as their magnitude ranges from micro to millivolts. Gain is the ratio of the amplifier's output to its input signal. Dr. Rigg here was one of my colleagues at residency, and he was the former lead guitar player for the Blue Oyster Cult. So that's a picture of him. If Dr. Rigg's guitar signal equals 10 and the amp puts out a signal of 110, what is the gain? So we said it's output over input. So the output is 110, the input is 10. So 110 divided by 10 gives you a factor of 11. And that's a reference to a movie called Spinal Tap. So the amplifier's resistance and capacitance are important parameters contributing to the amplifier impedance, and I am not going to go into this with you. But the point is to keep the electrode impedance low, if anyone asks. So let's talk about differential amplifiers. So a differential amplifier is basically two identical amplifiers, except that one is inverting the recorded signal and the other is keeping it in the same orientation. So if we had two electrodes seeing the exact same thing at the exact same time, then they would, one would be amplified, one would be amplified and inverted. And then when you add the two, you would get nothing, right? Because it cancels itself out algebraically. So everything that's different between the two electrodes is called difference mode signal, and everything that gets canceled is called common mode signal. The thing is, no two differential amplifiers have exactly the same gain, right? So if the gain is 10,000 in one of them, then it's probably going to be 9,999.999. Well, what does that mean? That means that everything won't be canceled out exactly, and a little bit of something will sneak through. This is called how good it is at letting everything, getting everything to cancel that's common, is called common mode rejection ratio. And this is something that's asked on the boards every year, and the answer is always 10,000 to 1 because that's the industry standard. The thing is that the engineers have far exceeded this, and it's really not an issue at these days. Only thing is to know it for the boards. So this is just a thought experiment. What if one amplifier didn't invert and you added them? Well, then you'd get twice the size of the signal. So this is the derivation of common mode rejection ratio from Dumitru's textbook. a colleague of mine, Dr. Kyle Steer, when I was explaining all of this to him, saw that it really didn't, you really didn't need that whole big derivation. As long as you know what the gains are, you can figure out the common mode rejection ratio. So this is, again, for one question on the boards, and for those of you who are a little geeky or engineering types. Surface electrode placement is really important for this reason. So if you put things too close together, then things are going to cancel out. If you don't put them close enough, then you're going to have noise seeping in. So for motor studies, we want to put E1 or active on the muscle belly, kind of where the neuromuscular junction would be. So that's the midpoint between the tendons. And E2 should be somewhere nearby, which would be on the tendon or on the bone nearby. If you put them too close together, then your amplitude will decrease. So for example, in this picture, we see that the amplitude has gotten smaller when the electrodes were put closer together. Both the base to peak and the peak to peak amplitudes became smaller. With sensory nerve action potentials, a separation of 4 centimeters is what we're looking for. If you do less than 4 centimeters, then you're going to get a reduced amplitude and a shortened peak latency. If you do it greater than 4 centimeters, it's really not going to affect it. It's going to really just let through a little bit more noise. See, here's the thing. With sensory nerve action potentials, we're looking at the microvolt range, and noise is in the microvolt range too. So that's the problem with snaps, is that we kind of want to have as quiet a baseline as we can, so we want to put those active and reference electrodes as close to each other as possible. But if we put them too close to each other, they're going to cancel out the waveform that we're looking at. And this can be actually derived by knowing that the velocity of nerves in the upper limbs is 50 meters per second. The time of the rise time is basically 0.8 milliseconds, and so then the distance can be calculated by saying distance over time equals velocity. And I have that all explained here for you, and you should look at this and understand it. So now we've picked up the electrodes as best we can as an interface with surface electrodes, fed them to a differential amplifier that has revealed the difference between the two electrodes, and then amplified that. Now we want to take out all the stuff that we don't really care about, and that's done by filters. So first thing we need to do is understand frequency spectrum analysis. Basically, any function can be broken down into a number of sine waves of both long wavelength, low frequency, and short wavelength or high frequency in different phases. So when I see this waveform, I understand that adding this to this to this to this to this algebraically gives you this waveform. So there's a low frequency component to it, and there's a high frequency component to it. And as you can see, the high frequency component is contributing to how quickly this deviates from the baseline. And then the low frequency component is kind of contributing to the duration and, I would say, the amplitude. So this is not a typical biological signal, but this one is. And so you can see how this, with this kind of, in this phase, etc., all of these add up algebraically to give you this waveform. So the question is, what if I remove some of these high frequency signals? What if I remove some of these low frequency signals, components to this waveform? So first of all, let's look at a compound muscle action potential and compare it, its low frequency and high frequency components. So we see that the rise time going from A to B is about 2 milliseconds, which correlates with a frequency of 500 hertz. That's a higher frequency, where the entire duration A to C is about 5 milliseconds. That's correlating with a lower frequency of 200 hertz. So just like I said, duration seems to be contributed to by lower frequencies, and the faster changing components such as onset latency and rise time seem to be affected more by high frequencies. So a filter is a device with the capability to exclude undesired signals which are outside the frequencies of interest, and we call that noise, but it includes the designated important information necessary to optimally assess biologic information. And a filter is, it's got the combination of a resistor and a capacitor, and how they're organized or how they're put together and connected in a circuit is what determines what will be filtered out and what will pass through. However, nowadays we're using digital filters, so that's all in the computer and you don't need to understand the whole resistor capacitor thing to do EMGs. One thing I would like you to know, though, is bandwidth. So when we have a high frequency filter, it's going to remove everything above a certain frequency. So if we've set this frequency to 2 kilohertz, then 2 kilohertz and above will be removed. If we have a low frequency filter, then we're going to remove everything from here down. So let's say it's 60 hertz. Then everything from here and down will be removed and filtered out. What that leaves you is everything in between. And that is what we call the bandwidth. And as we said, as you filter stuff out, it's going to affect your SNAP and your CMAP, and we'll talk about that in a moment. Notch filters are specifically used to remove the 60 cycle sine wave that comes from the electricity in all of our AC outlets. So if you do have a low frequency filter and you raise that low frequency filter, which means you're raising the frequency at which things are being removed. So more low frequencies are being removed. So if you elevate or increase the low frequency filter, that's going to affect all those things that the big waveforms are affecting: duration, amplitude. It's going to move your peak latency earlier. It's going to move your onset. It's not going to change your onset latency. And it's going to make you have more phases with time. On the CMAP, similar. If you lower the high frequency filter, which means we're taking away more high frequencies, kind of the opposite happens. You have the big difference here is that amplitude and duration aren't affected as much, but onset latency is affected. Filter effects on the MUAP, and these are the recommended filter settings. I used to go through these ad nauseum. I've given you the slides, and you can study them on your own now. Next is sound. A biologic signal going through the differential amplifier and filters eventually goes to a speaker, and it's converted into sound. And this is before the computer gets it. And this is helpful because a lot of us electromyographers hear the signal just as much as we see it, and you can really tell a lot about what's on the screen based on what you're hearing. For example, anything with a sharp clicky sound is going more likely to be closer to the needle, whereas if it's a low-pitched rumble, it's more likely to be away from the needle. So next we get to the computer, and basically all I want you to know is that there's a computer there and it's storing everything in ones and zeros. If you're interested, this is way more than any resident ever wants to know. One thing I do like pointing out is that everything goes in analog, and then once it's stored, it goes in digital. It's been basically pixelated. So the more bits you have, the less pixelated it looks. Just like a photo looks very pixelated when it's low resolution. So we want there to be as much high resolution as high a resolution as possible to have the best representation of the analog waveform that's being converted into digital. And we are going to move through this. Basically, digital costs less, easier to maintain. Sometimes the desired potential under investigation is so small that it's effectively hidden within the noise generated by surrounding muscle. So that could be EKG, EEG, and other electrical activity. The process of averaging extracts a signal that is time-locked to a depolarizing stimulus from the surrounding background noise by sequentially adding stored traces and dividing by the total number of responses. Basically, you stimulate the nerve and you get a small electrical response in a sea of noise. Each point in time is given a digital amplitude via analog to digital conversion and stored in the computer's memory. This process is repeated for a second stimulus, and the second stored response is added point for point to the first stored trace and then divided by 2. The trace that follows is the average of the two traces. The purpose of this is to basically improve the signal to noise ratio. That means the signal's amplitude should be a lot larger than the noise amplitude. And the factor that it improves by is the square root of the number of averages performed. So if you perform 4 iterations of this, then you'll get an improvement of 2 times the signal to noise ratio. You would have to do 9 to improve by from 2 to 3, and then you'd have to get up to 16 in order to do a further signal to noise improvement, which is why most people stop at about 9 to 10. Averaging cannot replace good technique, so do everything you can to improve the signal to noise ratio in other ways. Displays are the final component in the signal pathway. Display sensitivity is basically how big, how much voltage is being represented on the graph in the y-axis on the screen. This can be either done in volts per centimeter, microvolts per centimeter, or microvolts per division. As you increase the sensitivity, which means you're magnifying it, right? As you increase the sensitivity, you're going to have an easier time finding where the onset latency is, and so it's probably going to get earlier and earlier. Whereas with snaps, it really doesn't have that much of a difference because we're already quite magnified when looking at snaps. Trigger and delay is a way to take a firing waveform and put it on the same place in the screen at the same time. Stimulation and stimulators is a whole other topic. Basically, you can stimulate the nerve by using a surface electrode that's attached to a battery. And that's what the stimulator gun is, basically. It's a bunch of surface electrodes that are attached to a battery. When you press the button, current is delivered. Most of us use surface electrodes, although there are some people who do near nerve needle electrode stimulations. There's a difference between constant voltage versus constant current, and I believe the generally all of these stimulators are using constant current. So let's talk about electricity. Wow, I was really into electro back then. So the first thing is that you put the cathode on the skin, and you have the plasma membrane here, and you have all these positives and outside the cell, those are the sodiums, and all the negative macromolecules on the inside. This is the resting membrane potential. So the next thing that happens is, if you think of it as positives coming from the anode, positives are delivered to the skin. They get into the subcutaneous tissue, and now it's more positive outside the membrane than it was before. What this does is it induces the positives that are inside the cell to want to move away. And as we said, motion of charges is current. So an intracellular current was created, and then the adjacent membrane, the positives here repel the positives that are on the membrane here, and they are attracted to the cathode. So basically this is like a battery circuit that happened with a capacitor in the middle. And this is how stimulation occurs. Sometimes we make the mistake of putting the stimulator in the wrong orientation, and that can add a little extra distance to where you're stimulating, and that can incorrectly make your velocity seem slower. There are many ways to reduce stimulus artifact. Stimulus artifact is essentially the electricity from the stimulator going throughout the body and creating this waveform here, and this can obscure your initial onset takeoff. If you overstimulate, which means that you're delivering too much current to the body, then you can create a shortened onset latency in compound muscle action potentials, because effectively now, instead of stimulating here, you've stimulated a bigger area. Instead of a pebble in a pond, now you have a big boulder, and that creates a big splash, right? So there's more current here now, and that's a shorter distance that it's going. So it's an onset latency that's not supposed to be that short at that where you've stimulated. And then the other thing is, if you're stimulating near another nerve and you give too much current, it can stimulate the nearby nerve and contribute to the waveform. The most important aspect to remember regarding instrumentation is that the skills necessary to practice electrodiagnostic medicine ultimately depend on the practitioner and not the instrument, irrespective of sophistication. Meaning, if you don't turn on the amplifier or you haven't plugged in your wires, no matter how good the equipment is, it's not going to be able to compensate for that. So now we're going to move on to cell physiology. Before we can understand action potentials, we need to understand the structures which generate an action potential. The functional unit of the nervous tissue is the neuron or nerve cell. You'll eventually see that the plasma membrane or the cell membrane or axolemma or sarcolemma is the component of the neuron most directly relevant to electrodiagnosis. So the plasma membrane, we're going to go through function, structure, and transport. So when you first look at the plasma membrane, it may look a little bit overwhelming. Let's talk about function first. So it has a physical function and a physiologic function. The physical function is that it defines a boundary and it isolates the cytoplasm from the extracellular areas. It maintains the cell's structure and integrity and selects which things will get through the membrane. Well, the physiologic function is that it determines what can come in and what can't, so the composition of the cytoplasm, and it also mediates the interactions between the cell and its environment, controls intake and waste, and it produces and sustains gradients of both concentration and charge. And this is what ultimately defines the very identity of the cell, what's coming in, what's coming out, and what's on the surface. So it's one of the most fundamental structures of cellular evolution. Structurally, it's made of lipids, proteins, and carbs. It's about 50% lipids, 50% protein, and a little bit of it is carbs. So the lipids. The plasma membrane lipids are phospholipids, cholesterol, and glycolipids. Phospholipids, as you may not remember, are amphipathic molecules. So there's a glycerol polar head, and then there's these two nonpolar tails. If you put them in water, they'll spontaneously form either micelles or bilayers. So phospholipids have various different, there's various differences in their heads, glycerol heads, and also the kinking of their lipid tails. Fatty acid tails, I should say. Glycolipids have a carbohydrate component to them, and they're non-charged. Cholesterol is also part of the cell membrane. It's an important component. It's also an amphipathic molecule because of its polar hydroxyl group. Cholesterol is also a precursor to the steroid hormones such as testosterone and estradiol. And it's definitely in a sea of phospholipids. So let's talk about the physiology of the lipid bilayer. It's a two-dimensional fluid, and the fluidity depends on its composition. So you can have saturated fatty acid tails and unsaturated hydrocarbon tails. And the more unsaturated, the more fluid, the more saturated, the more viscous it's going to be. Another thing is that cholesterol, when it gets in between the phospholipids, can contribute to the fluidity, and sometimes it can contribute to it being less fluid depending on temperature. The lipid bilayer is asymmetrical, so there's lots of glycolipids on the outside, there's charged stuff on the inside, and sometimes there's interaction with proteins on the outside as well versus on the inside. It serves as a solvent for membrane proteins, which is where we're going to go next. So proteins, again, about half of the volume of the plasma membrane. They can be integral versus peripheral. They can be transmembrane, which means they're going all the way across the lipid bilayer. And we talked about the fluidity. So proteins, if you take a human cell and a mouse cell here, put them together, eventually the proteins of the two will become a little more heterogeneous rather than homogeneous areas. And cells can confine their proteins and lipids to specific domains within a membrane in order to offer better function. So you can see some versions of that here. Next slide also shows you that. So you have some proteins that are linked to the basal plasma membrane. Here it's to the lumen. Protein A is in the lumen. Protein B is between the tight junctions. Here we see a red blood cell and how it's got cytoskeletal proteins associated with it, and they're confined to different regions. There's different proteins in a sperm, in the head, in the neck, and in the tail. And that makes that point. In terms of carbs, we already talked about the fact that you can have glycoproteins. So the summary of the plasma membrane, basically it's an asymmetric lipid bilayer full of phospholipids, glycolipids, and cholesterol. They're fluid mosaics in which proteins are inserted into phospholipid bilayers and they diffuse laterally through the phospholipid bilayer. There is some mobility, but sometimes they can be also restricted to different places. The carbohydrate can serve as a marker for cell recognition, and associated proteins carry out specific membranes. Functions. So here we see it again, and it doesn't look that hard to understand what we're dealing with anymore. Let's talk about transport across the membrane. You can have passive transport, which can be basically just going through due to diffusion, facilitated diffusion, which means you need a protein. And then finally, active transport requires energy. Passive transport first. Basically, it's the simplest mechanism by which molecules can cross the plasma membrane. A molecule simply dissolves in the phospholipid bilayer, diffuses across it, and then dissolves in the aqueous solution at the other side of the membrane. No membrane proteins are involved, and the direction of transport is determined simply by the relative concentrations of the molecule inside and outside of the cell. The net flow of molecules is always down their concentration gradient from a compartment with a high concentration to one with a lower concentration of the molecule. The membrane will only allow passage of small and uncharged or non-polar molecules. So even if it's small, like hydrogen, the hydrogen ion is not going to get through because it's charged. So for these small charged ions, we do need channel proteins, which will form a water-filled tunnel through the membrane for passive passage of substances. And the rate of this simple diffusion depends on the kinetic energy of the system, the number of membrane openings, and the concentration gradient. These channels are characteristically specific for certain ions. Carrier proteins are different in that they don't just form a pore. They are going to change conformation after they bind with whatever molecule or ion it is that they are transporting, and then release it to the other side. Channel proteins, like I said, form hydrophilic pores for ions, but they're not like gap junctions and porins. They're not just large permissive aqueous pores. They actually have ion selectivity. They tend to be gated, which means they can be in an open or closed state, allowing diffusion to occur. So we talked about ion selectivity. So this will permit some inorganic ions to pass, but not others. This suggests that their pores must be narrow enough in places to force permeating ions into intimate contact with the walls of the channel so that only ions of appropriate size and charge can pass. The permeating ions have to shed most or all of their associated water molecules to pass, often in single file through the narrowest part of the channel, which is called a selectivity filter. This limits their rate of passage. Thus, as ion concentrations are increased, the flux of ions through a channel increases proportionally, but then levels off because it saturates at a maximum rate. Perhaps the most common ion channels are those that are permeable mainly to potassium. These channels are found in the plasma membrane of almost all animal cells. An important subset of potassium channels are open even in an unstimulated or resting cell and are hence sometimes called potassium leak channels. Although this term covers a variety of different potassium channels, depending on the cell type, they serve a common purpose. By making the plasma membrane much more permeable to potassium than to other ions, they have a crucial role in maintaining the membrane potential across all plasma membranes. The second important distinction between ion channels and simple aqueous pores is that ion channels are not continuously open. Instead, they're gated, which allows them to open briefly and then close again. In most cases, it's in response to a specific stimulus. And the main types are a change in voltage across the membrane, a mechanical stress, like a shear, or binding of a ligand. The ligand can be either an extracellular mediator, specifically a neurotransmitter, which are transmitter-gated channels, or an intracellular mediator, such as an ion, which are ion-gated channels. It can also be nucleotides. The activity of many ion channels is regulated in addition by protein phosphorylation and dephosphorylation. This type of channel regulation is usually more with the nucleotide-gated ion channels. So what's really important here is because when we talk about the action potential, there's a lot of voltage gating going on. So now let's talk about active transport. We learned all about the fact that you need energy in the form of ATP to move ions or molecules against their concentration gradient. So we talked about simple diffusion, facilitated diffusion, and active transport after having talked about the plasma membrane structure. Now we have enough information to understand the membrane potential. So this is where things start getting interesting, and it's all about the ions from here on. So first, I think it's good to think about what's happening with concentration, and then you understand that voltage is a byproduct of the concentration changes. So what you have is a cell, and inside the cell, there are these large macromolecules, and they're all negatively charged. And they attract lots of small positive counter ions. And as the macromolecules sit there and are attracting these counter ions, there's also an attraction of water to the increased concentration inside the cell as compared to outside the cell. The problem with this is that as the water keeps going in, it's going to make the cell want to explode, and that's not a good situation. So if you look at amoebae, they actually pump water out. If you look at plant cells, they use the cell walls to resist the tendency to explode. So what do us animals use? We use the sodium-potassium pump. So for every 2 potassiums that come in, 3 sodiums go out, which is a net difference of 1. And as this is happening, you're also having a net difference in charge, which is what makes the sodium-potassium pump electrogenic, creating a resting membrane potential for your cell membranes. This is a description in Dumitru about non-permeable versus semi-permeable solutions, and I do recommend you look at this to understand the electrogenic nature of semi-permeable membranes. Here is the second slide. So membrane potential changes can occur with just movement of very few charges leaving one side to the other, and so concentrations will probably not be very much affected as much as voltage is, and these movements of charges are generally happening very fast, within a few milliseconds. We talked about the potassium leak channels. So if you do kill the pump, the sodium-potassium pump, probably what happens is you get loss of the ability to maintain the structure of the cell, and it's going to burst. The resting membrane potential arises when there's that difference created by the sodium-potassium pump on the 2 sides of the membrane. The equilibrium condition in which there is no net flow of ions across the plasma membrane defines the resting membrane potential. The inside is negative with respect to the outside, and it's usually listed as negative 70 to 90 millivolts. When the inside becomes more negative, it's called hyperpolarized. When the cell inside becomes less negative or more positive, we could say. It's depolarized. It's determined by the Nernst equation, and the Goldman-Hodgkin-Katz equation is what relates concentrations to with permeability at the membrane. So now that we've talked about what happens at the cell membrane at rest, let's define the anatomy of a motor unit, and from there we can talk about the classic experiments that determined how the action potential works. So a neuron is the structural and functional unit of the nervous system, and its function is to receive and conduct and transmit signals from one part of the body to another. And you should know all the different components of the neuron. You can classify it by its shape. It can be multipolar, bipolar, or unipolar. Groups of neurons can also be labeled as, depending on whether they're in the central nervous system or peripheral nervous system. Groups of neurons in the central nervous system are called a nucleus, and a group in the periphery is called a ganglion. So let's talk about some classic experiments. The first was sticking an electrode inside a membrane, and by doing this, they were able to see what was conducting at what times inside the plasma membrane compared to outside. I call this the toothpaste one. Basically, they squeeze out, roll out all the stuff that's inside the axon and fill it with whatever they wanted to. So you could just use sodium ions, or you could just use potassium ions, and then see how the membrane was behaving depending on this. So what they were able to find was at rest, the membrane is chiefly permeable to potassium, and during the action potential, it becomes transiently permeable to sodium by doing all of that. Then there's the patch clamp technique. So what this means is you take a micropipette and squeeze off just a little tiny bit of the membrane. You can get so close, you can get such a small piece that you could get one channel and see how it works when you're using the toothpaste situation as well. And then the clamping is that you apply a voltage to it and maintain that voltage. That's called the clamp. You're clamping the voltage down. So the membrane potential is applied, clamped, and what you see is transiently increased sodium conductance and then delayed potassium conductance. And this is how we learned about the action potential. So how do voltage-gated channels work? We know that there's these voltage-gated potassium channels, and we actually do know how these work. If you take a look here, they're showing you this like little ball on a rope, and this goes up in there and blocks it. Here we have this guy folding in to give you this, and what happens is basically at resting membrane potential, there's certain electrical forces influencing the proteins all around the membrane. As soon as there's a change there, then there's new forces exerted on the charged moieties of each channel. And this is going to cause them to want to adopt a new conformation. While they're adopting that new conformation, they're opening and then seemingly closing, which is how you get your active and inactive gates. And we've been able to look at how just one channel looks when it's opening or closing. And these are all the properties of it. Patch clamp techniques looking at a single channel, another single channel, another single channel, and being able to document how long it was open and what it was doing is pretty freaking amazing. So what happens in a real membrane? Well, that depends on whether you're exerting a subthreshold or threshold potential, depolarization to the membrane. So you'll remember I talked about capacitors as being two conductive plates separated by a non-conductive film, and then positives are moving onto the plate that makes the dipole in the middle, and then positives are basically going to want to leave this other plate, go down the wire, and you've basically had current occur without anything going across this insulator. So that was capacitive current. And the cell membrane acts as both a resistor and a capacitor. It's a resistor because nothing can get through it. It's a capacitor because you've got these hydrophilic plates, which are the heads on the outside, and then on the inside you have the fatty acid tails, which are the insulator. And so you can similarly develop subthreshold currents being influenced from outside to inside or inside to outside. So when the voltage-gated channels open, then the resistance through the membrane becomes very, very small, and charges can flow through, and then you can have transmembrane current as a result of that. Now that's different from the capacitive current I was talking about, where charges are accumulating on the outside and influencing what's on the inside. So an action potential is an all or none self-sustaining rapid transient reversal of transmembrane potential based on ion permeability shifts. The nervous system has developed this simple, highly efficient means of relaying information and reacting to stimuli by means of electrical impulses. They're self-sustaining ion permeability shifts known as action potential. And it's an initial depolarization through an inward directed sodium ion flow followed by a repolarizing outward directed potassium current. And you have all these states. The first state is the steady state, and this is what we talked about as the resting membrane potential, where sodium is being pumped out, potassium is pumped in, but it's more sodium out than in. There's a lot of potassium permeability because of the leak channels. There's a little bit of chloride, but very, very, very rare sodium leakage. And voltage-gated channels are closed. The resting potential is between negative 70 and 90 on the inside. So a transmembrane voltage of negative 70 or negative 50, depending on what you read, initiates a conformational change in the voltage-gated sodium and potassium channels. And these happen at exactly the same time. The conformation change in both voltage-gated sodium and potassium channels occur at the same time. That voltage, which is required to do that, is called the threshold potential. So now the activated open sodium channels allow rapid influx, and the permeability is increased about 5,000 times. There's a conformational change of potassium channels occurring, but it's happening much slower, resulting in a delayed potassium efflux. Repolarization is that the potential after reaches plus 40, plus 50, and sodium gates approximately 1 millisecond later are inactivated as a result. And the delayed opening of the potassium channel now occurs, resulting in a rapid efflux of potassium, and actually very few in number, as I had mentioned before. This returns the membrane to its resting potential, and we reach this point where it's an absolute refractory period, meaning it doesn't matter how much voltage you throw at it, it's never going to generate a new action potential at this moment because the sodium channels are inactivated. Hyperpolarization is when the potassium channels they're just a bit slow to close. They're open a bit longer than required, resulting in a more hyperpolarized negative state. And this is now the relative refractory period. So sodium channels are no longer inactive, they're closed. So you can now depolarize the membrane, but it's just going to take more current or more voltage to initiate an action potential because of the hyperpolarization. Repolarization, finally, is when the voltage-gated potassium channels close. They were really slow to close, but now they're closed, and the membrane potential resets as potassium equilibrates through the leak channels. The inactivation gates reopen sodium channels, and the activation gates close. During this time now, you can generate an action potential normally. So action potentials will propagate across the membrane in one of three ways. They can either go inside the membrane, they can go outside the membrane, or they can go through the membrane. So with a unmyelinated normal neuron, you'll have sodiums coming in and depolarizing neighboring membrane, and that's going to cause the neighboring membrane to need to depolarize as well, action potential to occur and depolarize as well. And this keeps happening So it's like da 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 like this, and it's propagating in this direction, and it can't propagate backwards because these are in their inactive absolute refractory state. Myelin is formed by specialized supporting cells called glial cells. Schwann cells myelinate axons in the peripheral nerves, and oligodendrocytes do so in the central nervous system. They wrap layer upon layer of their own plasma membrane in a tight spiral around the axon, thereby insulating the axonal membrane so that little current can leak across it. The myelin sheath is interrupted at regular spaces called nodes of Ranvier, where almost all the sodium channels in the axon are concentrated. Because the ensheathed portions of the axonal membrane have excellent cable properties, in other words, they behave electrically much like a well-designed underwater telegraph cable, a depolarization of the membrane at one node almost immediately spreads passively to the next node. And this is happening by, again, as I told you, the sodium's coming in and traveling to neighboring membrane. And that's how action potentials propagate. They go inside, and here they're depolarizing all the membrane that's neighboring. Once they get to a node, another giant well of sodiums come in, and this is how action potentials propagate in myelinated membrane. So optimizing the myelinated nerve happens by getting a nice thick myelination, as well as keeping the distance between nodes the right length. If you were to take a big giant cell axon, giant squid axon, and compare it to a microscopic myelinated nerve, even though it's got all that cross-sectional area, the cable properties of the myelinated nerve are far better than that of the giant squid axon. So we've gone through the plasma membrane, the membrane potential, and now we just talked about the neuron and the Schwann cells. Let's remember that we're looking at a motor unit. So the neuron's cell body sits here in the anterior horn, and an axon projects through the ventral root, joins the dorsal root ganglion to form a spinal nerve, and then leaves to join plexuses, peripheral nerves, and eventually gets to the muscle, where it gets a neuromuscular junction occurs at the meeting point of the muscle. Neuromuscular junctions are pretty cool to see in scanning electron microscopes, but basically you can see that there's a primary cleft and lots of tiny secondary clefts to improve the surface area of the neuromuscular junction. Here we see from Dumitru's textbook, it looks kind of like a glomerulus, and then when it reaches the muscle, here's one primary cleft, and here are the secondary clefts. You can see mitochondria inside the muscle membrane. This is the axon terminal. Then there's the synaptic space, and then there's the motor muscle end plate, is the distal part of the neuromuscular junction. More cool pictures of neuromuscular junctions. More cool pictures of neuromuscular junctions. So the motor unit, we just talked about the anatomy of it. I do think I have slides on development. Yeah, embryologic development of muscle for those who are interested. And then how satellite cells can contribute to the syncytium. And the different muscle cell categories, which you should remember. Smooth muscle cells, which are located in a lot of autonomic structures. Striated is the one that we talk about, which can be both cardiac muscle and skeletal muscle, the one we're most interested in. We can talk about hierarchy. Basically, you have a muscle belly, such as biceps, which is made up of fascicles. These are the fascicles. A fascicle is a bundle of muscle fibers. A muscle fiber is a muscle cell. Muscle fibers are made up of myofibrils, and there's a whole bunch of proteins that make those, and each of these repeating units are called sarcomeres. The hierarchy of skeletal muscle again. Histology of it. Basically, you should know that it has a cell membrane called the sarcolemma, and inside the cytoplasm is called the sarcoplasm. the myofibrils, sarcomeres, mitochondria, sarcoplasmic reticulum. Lots of stuff for you to read. There's plenty of connective tissue surrounding both neurons and muscle. Connective tissue has a huge component of collagen, and you learned in medical school how collagen is made of these monomers which come together to form fibrils. The fibrils form fibers, the fibers form fiber bundles, and then finally you have fascicles. It's very similar to the hierarchy of muscle, and here we have models of it, and there are crosslinks, and this is a summary of how it aggregates. So muscular connective tissue depends on collagen, and we have multiple layers of collagen, soft tissue, connective tissue surrounding the muscle. So the first layer is epimysium, which surrounds the entire muscle belly, and it merges at its end with the tendon. It's made of dense, irregular, collagenous connective tissue. Next is the perimysium, which in this picture we can see it's kind of septate and it's getting on the inside, separating the fascicles. And then you have endomysium around each of these muscle cells, and it's a loose, delicate mesh of fine reticular fibers separating each muscle fiber from each other, each one from its neighbor. If you didn't do that, then electrical potentials can bridge from one to the other. If haptic communication like that results in what we call complex repetitive discharges. Sarcolemma versus plasma membrane. Sometimes people say the plasma lemma is the cell membrane of each muscle syncytial fiber, while the sarcolemma is the plasma membrane plus the cytoskeleton. It's kind of splitting hairs. The myotendinous junction, I haven't been able to find these pictures since I first found them, but basically it's not a really well-defined area where the muscle meets the tendon, and so therefore it is a little bit on the weak side. Tendinopathy is when you lose the orderly structure of tendon when it becomes unhealthy and more vascularized. I do talk about vascularity of muscle. And then T-tubules are basically sarcolemmal invaginations. I love this picture here. Shows it going deep into the cell. And by having an action potential propagate on the muscle cell down into the muscle cell, it's getting access to the inside of the muscle where all those fascicles, deep fascicles, reside. And so they're sitting next to, these invaginations are sitting next to sarcoplasmic reticular sacs, and these are called terminal cisternae. So by having the depolarization come down here, it causes these terminal cisternae to release calcium, which is important for muscle contraction. A triad is basically a T-tubule flanked by two terminal cisternae. I just showed you that. Here's another cool looking picture of that. Sarcomeres are the functional units of the myofibril, and they're repeating, and that's where you see the lines going down here. You can see them as well. And back in medical school, you did learn the names of all the Z discs, the H zone, the A bands, etc. So a cross-section of the myofibril under electron microscopy reveals patterns of large and small dots, and these are the thick and thin filaments. So if you cross through here, you see just all these thick filaments. If you cross through here, you see just like a thinner version of that, and then here you see very thin filaments. If you look between where both of them are, then you see both of them, the thicker and the thin. The sliding filament theory basically talks about how the thick filaments sit where they are and the thin filaments slide across them. That's how you get contraction. There are so many thick filaments that we know about, and they have different functions, and they're fascinating. Never come up in electrodiagnosis, though. In order to prevent the actin and the myosin thick and thin filaments from interacting at all times, tropomyosin covers the active sites of actin, and troponin is the molecule that controls whether tropomyosin is covering or not. Troponin T attaches to the tropomyosin molecule, troponin C binds calcium, and troponin I inhibits interaction between the thin and thick filaments. There's lots of other proteins, like I said. So first, let's now go back, and the nerve cell body membrane depolarizes, and an impulse is carried along the axon of the motor neuron. When that happens, the presynaptic membrane is eventually depolarized, which means sodium is influxing. Now, because of that change in potential, the axon terminal is now positive, and that leads to opening of voltage-gated calcium channels in the axon terminal's membrane. This influx of calcium increases the intracytosolic calcium and causes vesicles of acetylcholine to be released from the presynaptic membrane into the synapse. So these are all the different stages, including tethering, docking, priming, fusion, and then eventually endocytosis to recycle the vesicles. And there's plenty of different proteins involved. These proteins are important because we've been developing neurotoxins to block these. So this is a summary of what's happening on the postsynaptic side. So you have all this acetylcholine that's going across the membrane. Some of it gets eaten up by acetylcholinesterase, about 50% of it. The other 50% gets to the other side, and acetylcholine receptors are activated, about 2 acetylcholines per receptor. And what that does is it allows sodium, potassium, calcium to all go down their gradient into the muscle cell, and then this causes activation of nearby voltage-gated calcium channels, and then you get propagation of an action potential down the muscle membrane, and then that leads to contraction. So the way contraction occurs is the power stroke. This was an animation. I'm not sure why it's not working, but basically it needs ATP to cause the heavy chain myosin complex to attach to the actin helix, and then it moves this along like a ratcheting, and it needs ATP to disengage. This is from Dumitru as well, and it's talking about the fact that there's a huge store of acetylcholine vesicles waiting in the cell body, and there is a that's the surplus, but there's an immediately available store right there at the axon terminal. We talked about this. I talked about this already. Each vesicle of acetylcholine is called a quanta. I believe quantum, but quanta. Single quantal release is occurring regularly and spontaneously because there's a certain amount of intracytosolic presynaptic calcium that just can't be completely removed. And so that causes the vesicle to release into the synapse, and all the acetylcholines that attach to the other side at the muscle end plate cause a miniature end plate potential to occur. And because it's so small, it doesn't lead to propagation along the postsynaptic membrane. But when the needle of the monopolar needle is near a neuromuscular junction, you're hearing all these different miniature end plate potentials being released, and it sounds like a seashell sound. Those are all miniature end plate potentials. Here's another view of the power stroke. And there is a little delay between excitation and contraction. Here's the power stroke. Here's another view of the power stroke. The resting membrane potential approaches about -90 as well, and that's the equilibrium potential of potassium. The invaginated T tubules possess many more potassium channels than the surface sarcolemma, and that's because the buildup of charges within the narrow T tubules restricts rapid diffusion of potassium through the ion channels and into the extracellular space. If you have issues there, then you can have, if you have like channelopathies, like with myotonic dystrophy, that's where the issue can be. Action potential propagation along the muscle membrane takes much longer. It's about 3 to 5 meters per second, as opposed to the upper limb nerve conduction velocity, which is 50 meters per second. And that's due to the extensive surface area created by the T-tubules. After depolarization, potassium leaves the cell to repolarize the cell. However, the potassium charges accumulate extracellularly within the T-tubule space, making the transmembrane potential more positive. And so this is a bias towards depolarization known as after depolarization, which can last for several hundred milliseconds and may summate with repetitive activity. Nature has obviated repetitive muscle firing of this nature by providing the sarcolemma with 10 times greater chloride channels than potassium conductance. This means that only a small amount of potassium needs to leave the cell for repolarization, since there's a concomitant influx of negative chloride ions. And so that kind of covers the old slides that weren't covered for you before. I'm now going to include some of my technique slides that were requested by the residents, and I didn't put them on any of the other presentations. So we've already covered the electrodes and surface versus needle, cathode, anode, and talked about nerve and muscle. So for stimulation, there's a little bit of time that it takes, 0.1 milliseconds between the time you press the button and it takes for the cathode to deliver current and initiate sodium activation. That's kind of just accepted and no one talks about it. Threshold stimulus is when it's just enough current capable of evoking a little potential. Subthreshold would be anything less than that. Maximal stimulus is when after you're increasing the current, it doesn't increase anymore. The waveform doesn't increase in size anymore. Submaximal would be between threshold and maximal. Supramaximal is when you add another 20% of current to the maximal current. Pulse width or duration is how long the square wave is delivering the electricity. So my approach basically to synapse, but applies to CMAPs as well. First of all, you want to clean the skin as much as possible. And that's to remove all the components of the skin, dirt, oil, stratum corneum, dead skin cells that are contributing to impedance. Secure all 3 electrodes either with tape or, if they're self-adhesive, make sure that they're actually sticking. Then you measure along the course of the nerve for the cathode, which is where the light is on your stimulator wand. So start with 100 milliseconds duration, 0 milliamps to check that, the machine is on, and then slowly increase the stimulus current 10 milliamps at a time. As soon as you reach threshold, and there's a little nub there, move the cathode laterally or medially to get the biggest response, and that ensures that you're over the nerve. And then after that, you can continue elevating the current 10 milliamps at a time until you've reached max. Then add 20%, that's supramax. And while you're doing this, you want to watch that the waveform isn't changing. Changing in amplitude's fine, but just that the morphology isn't like suddenly changing to something different, because if that happens, then maybe you're giving so much current that it's actually stimulating a nearby nerve, and that's contributing to the waveform. If you don't have a response, check your equipment, make sure everything's plugged in. If it's a snap, you could consider using averaging. They also suggest you could use near nerve needle electrode stimulation. I have done that very rarely. And store the waveform and commit to that waveform once you feel that you've got a consistent supramaximal response. For compound muscle potentials, you want to obtain a negative deflection, which means upgoing. So if it's a positive deflection initially, downward, you want to move the active around to make sure that you're right over the motor point. They may have a motor point that's just a little different than most other people. And especially if you're in the hand or in the foot, there's a lot of muscles there, so you might be receiving some contribution from others. Make sure that you're actually over the nerve that you want to stimulate and not over the one, not closer to the one that's nearby. And there's something called a premotor potential in the median nerve, where basically you're getting actually the snap from the palmar branch preceding the motor. It's very cool. You can see that in Dumitru's book if you're interested. For snaps, I think it's really important to scrub, like I said before. And one of my attendings had said, less gel, more tape, which means if you put too much gel on, you're probably going to get bridging. And the tape is really important to keeping it secure and keep it from moving. Now, in the upper limbs, you want to separate the electrodes by at least 4 centimeters. If you do less than that, then you're going to get cancellation of your amplitude. And also, don't crank up the stimulus right away. Start low, go slow, and you can watch how it's behaving. And if you do get stim artifact, I gave you another slide with all the different things you can do. You can obviously remove the electrodes and scrub the whole hand again once more, put it back, put the electrodes back. And then there's something called anodal rotation, which was described in the other slide.